Okay guys, here we go again. Respiratory system based off of chapter 7. This one's a little longer than normal, so hang in there with me. But we have some really important discussions about, viral illnesses, COVID, asthma, and general physiology as well. So let's get into it. So we'll start off just with some basic physiology. Obviously, as you know, your lungs are responsible for exhaling carbon dioxide and inhaling oxygen. And ventilation is the process technically of moving the air into your lungs. And oxygenation is what occurs at the alveolar level, and where the oxygen and the CO2 actually diffuse across the membranes. I want you to also think about, the respiratory system and its role in your acid-base status. For instance, if you have like a metabolic acidosis or alkalosis, your body will adjust your respiratory rate in order to blow off more CO2, and because CO2 is acidic, and so then it tries to adjust your pH that way. So the respiratory system can give us clues about a lot more than just your breathing status. So your book goes through a really in-depth discussion about, the upper respiratory tract and such. And your upper respiratory tract involves, like, your nose, your sinuses, your nasopharynx, your oropharynx. And it's mainly responsible for warming, humidifying, and filtering the air as it reaches the lower respiratory tract. So part of that, lots of women in particular get really embarrassed about their nose hairs, but those nose hairs serve a purpose. They help trap debris and, bacteria before it can get into your lungs. And then obviously this picture is satire, but your nose is connected to your lungs. Make sure you wear that mask up over your nose. This is just a picture of just what we talked about. The blue arrows follow the track of inspiration and through all of those different parts, including, like I said, nasopharynx or oropharynx, larynx, and like your vocal cords. Okay, so now we're looking more at the lower respiratory tract. You have your trachea that then split into your primary bronchi, which then splits into your bronchioles, which have the alveoli at the end point at the smallest level. And as you can see in the bottom right of this diagram, there's a lot of capillary beds in those structures, and that's where the oxygenation actually takes place. Also important to note that your right lung has 3 lobes, upper, middle, and lower, whereas your left lung only has 2, and that's because there needs to be room for your heart. Okay, and then evaluation of the respiratory system. These symbols mean absolutely nothing. I just thought they were funny. We've talked about history taking in the past, inspection, respiratory patterns, palpation, percussion, and auscultation, and we'll go through each one of these individually. Okay, so for your history, if somebody has a respiratory complaint, remember your old carts and news. So onset, location, duration, characteristics, aggravating factors, relieving factors, treatments they've tried, and severity. And then your news is how has it affected your nutrition. E is either how are you coping, like how are your emotions, or elimination. And then W is how has it affected your work. And then S is how it affects your sleep. And honestly, after you've been doing this quite a lot, most of the time I can have a running differential just based off of those two things. And a lot of times I can actually figure out what it was. But then specific to the respiratory system, they want you to ask about cough, shortness of breath, chest pain. Oh, and you'll hear me throughout this presentation use the word dyspnea, which is essentially shortness of breath. But part of medicine is making easy concepts sound really complicated, and so that's one of the examples. You also want to find out if they have a previous history of respiratory infections, which I think is kind of funny because I mean everyone has, but I think they're asking about, you know, more severe, as in like pneumonia or something like that. Any smoking or environmental exposure history, family history. And remember, with your review of systems, you need to do at least the system above and system below. So in this case, I would ask the HENT questions for head, ear, nose, throat. I would ask cardiac as well, and I would ask GI, because like we talked about previously, one cause of chronic cough can actually be reflux. Okay, so inspection, like we've said, inspection starts as soon as you walk up, as soon as you see that patient. You're gonna evaluate how fast, are they breathing really fast? Are they not breathing very fast at all? What's the rhythm? Is it really sporadic or is it kind of even? And does it look like they're working really hard to breathe? And this isn't something that, you know, you have to be able to quantify, but just like you would know if somebody is, you know, trying hard to breathe. There's so much that goes into that. Skin color and condition. Obviously this is based off of ethnicity as well, because, you know, darker skinned people don't turn that, you know, perfect cyanosis for us. You also want to check what posture they're breathing in and any use of accessory muscles. Like, for instance, there's the tripod posture, and that's like, you know, when you're pushing the shopping cart and you kind of bend forward and lean on it. That's called the tripod posture, and a lot of patients with COPD and emphysema use that in order to get more air in. And then accessory muscles, are the muscles moving in and contracting in between the ribs even? And that's a huge clue if you're looking at, you know, young patients like kids. Inspect the chest for shape and configurations. People with COPD kind of get this barrel chest, meaning their diameter is like the proportions aren't the way that they should be. And then inspect the chest for potential bruising of ribs or chest wall. Super important for you guys in sports medicine, as that would probably be a pretty common cause of symptoms. These are some of the different chest configurations that are normal. I think it's really funny that each one of these guys has a six-pack. Obviously not everybody does, but if you look at like their pecs and such, there's differences in gaps in kind of the areas of the musculature. And obviously, like the guy on the far left is a lot more broad-chested versus maybe the third guy has more of a narrow chest. Okay, so respiratory patterns. This is a common joke in healthcare that respiratory rate documented in vitals is, you know, the biggest lie ever, because we're not always the most thorough at actually counting them. And once you see a lot of people breathing, it's pretty easy to estimate. But it really is obviously best if you count them. And so most of the time we do over 30 seconds at least, and then multiply by 2. So tachypnea is rapid breathing, anything over 24 breaths a minute. And these are rates for adults, so keep that in mind, because it's normal for like an infant to breathe 30 to 60 times a minute. Hyperpnea, I've honestly never used that, or hypopnea. never used that to describe anything either. And then, bradypnea is that slow breathing, 12 breaths or less. Orthopnea is like shortness of breath when laying down, and that can actually be a sign of heart failure because when they lay down, the fluid is dependent, so it kind of shifts to that back, and they have a harder time ventilating and oxygenating. Palpation, you want to palpate any point of tenderness or mass. Obviously, if your patient just, if they're in a contact or a high contact sport and they take a hit and then they're having pain, obviously you want to palpate over that because you're looking for fractures. You want to confirm symmetrical expansion. And so what you do with that is you put your thumbs together with your fingers spread out. If anybody knows, how you block as a volleyball player, winners block with W's, losers block with L's. So you want to have that W on their back and put it on their lower back and have them take a deep breath, and both sides should move the same amount. And then you palpate for tactile fremitus because there's different, if there's fluid consolidation underneath it, the vibrations will feel less. Honestly, I don't do this a lot, partially because, I'm an ordering prescriber, so I can just get a chest x-ray. But I found that there's so many different factors that can affect this that I don't feel like it's the most reliable. And then percussion, these are the different sounds you would expect. Normal lung tissue is like that resonant sound. If it's an emphysema lung, it'll be like a hyperresonance. And you can YouTube these different sounds as well to get used to them. And the more you percuss, the better you'll get at it. So I would say even just practice on yourself. And these are the areas of what you should normally hear with percussion. And then auscultation, obviously you want to listen to both people's front, the front of their chest and the back. I don't know how many times I've seen a cardiologist come in and just listen in 2 points and call it a day. You'll hear the best if you have the stethoscope, the diaphragm of the stethoscope directly on the skin. And then if you want to look and sound super smart, you can do egophony. And egophony is you listen over several different points over their lung fields, and you have them say the letter E. And if there's an area of consolidation, most often a pneumonia, when you listen over that area and they say E, it will sound like ah. And then that's a good way to screen for pneumonia. There's a whole bunch of, this is something that everybody kind of has to learn, but I don't necessarily feel like it's the most helpful. At different areas of the lung tissue, you'll hear bronchial breath sounds versus bronchiovesicular breath sounds versus vesicular. And then when the disease affects the lungs, these areas are altered. I've specifically never really used this either. I more describe the sounds that I'm hearing. Your book also goes through, describing the frequency, the loudness, the quality, the duration, but once again, I don't use that either, so I didn't even bother to put it in here. This is a visual representation of where you're actually listening and what lobes you're actually listening to. So to get the lower lobes, you really have to listen on the back. So in that example of all the cardiologists, just listening to, I don't know if you can see my pointer thing. If the cardiologist only listens right here and right here, they're really not getting that much information. And then this is an example of where you would hear the different types of lung sounds. But like I said, most of the time I don't really care. Okay, so abnormal breath sounds. Crackles. Crackles kind of sound like bubbling, okay? And perhaps in your lab this week, you guys could go through and listen to some different sounds so you know what you're listening for. I'm pretty sure all of us have heard wheezes. That's that like high-pitched kind of wheeze. That's not a good description. Yeah, I'll find some good videos and send them over to James to help with that. Plural rubs. If you put your hand over your ear and like plug the external auditory meatus, and then rub your other finger up and down along your hand, like on the outside. That's what a plural rub sounds like. Stridor is also, it's different from a wheeze, and because the source is kind of more in those upper airway tracts, but it's this awful high-pitched sound that it makes you feel like the patient's going to die any second, but really they're not. Okay, let's talk about some actual conditions. So asthma, the important thing to remember is that asthma is a reversible airway obstruction, okay? Meaning somebody presents with symptoms of obstruction, but we can give them medicines and it will resolve, okay? Your book uses the term twitchy airways. I've never heard of that for asthma, but okay. The two components that lead to this obstruction are inflammation and spasm. So if the epithelia of the bronchioles are super inflamed, then that narrows the actual amount of air that can go through, or that bronchiole can actually spasm and close off. So for asthma, it's super important to identify triggers. It can be allergens, stress or anxiety, smoke or other environmental pollutants, just cold air, also, illness, any upper respiratory infection, or exercise. So this is all about exercise-induced bronchospasm, which we just talked about how, exercise can, be a trigger for asthma. And I find it kind of funny that there's this whole, decision tree for that to decide what the cause is. You guys won't be doing spirometry testing, I don't believe. Like even I have to, like my medical assistants can do it, but oftentimes I have to send somebody to a pulmonologist in a PFT lab. And but really what's funny is often what we do is if somebody comes in and says, I'm wheezing when I exercise, we give them an albuterol inhaler. If it gets better, great, we figured it out. If it doesn't, then we explore more. Because the risks of albuterol are so low, and it's an easy intervention, and it saves a lot of healthcare dollars as well. So here is the exercise-induced bronchospasm. Technically, it is defined as 10 to 15 minutes after onset of strenuous exercise, and is defined by a fall in FEV1 of 15% or more during exercise spirometry. So FEV is the forced expiratory volume and the 1 is over 1 second. So how fast can you get that air out? And if that's decreased, then that is the, technical definition of exercise-induced bronchospasm. It's more common in winter sport athletes who compete in cold temperatures, okay? But like I said, most of the time, we're not really doing spirometry. It's like, here, try an inhaler, take it 10 to 15 minutes before exercise, see if it helps. So COPD. This is the non-reversible airway obstruction. Okay, so remember, asthma is reversible. This is non-reversible. And what I mean by that is if I am actually doing like spirometry and I'm looking at their graph, which is horribly complicated and I'm not going to go into it, but I'm looking to see at one of those numbers. One of them is the FEV1. How much air can they get out really fast? So I have them do that, and then I give them a bronchodilator, and then I test again. And if it goes back, if it increases, like how much air they can get out, then that's reversible. If it doesn't, it's non-reversible. Two main categories of COPD is emphysema and chronic bronchitis. Technically, chronic bronchitis is a cough lasting longer than 3 months. But it's also hallmarked by excessive mucus production with upper airway obstruction. And then emphysema is that destruction of the alveoli and pulmonary capillary bed. Most of the time, COPD is from tobacco use. Okay, pneumonia is kind of a broad term given to any condition that results in inflammation of the lung parenchyma. It's usually infectious, viral, bacterial, fungal, but also aspiration. So if somebody is a little bit sedated or, you know, they had a wild night at a party and their breathing was slowed, they can aspirate contents into their lungs, which is a fancy way of saying choking. And maybe it's food or, you know, something else, and it can hang out in their lungs themselves, and then that can become infected. Viral or bacterial are the most common. Fungal infections typically occur most often in the immunocompromised patient. So if your athlete gets like a fungal infection, that should be a sign to look further. Pleurisy is a term to describe any inflammation of the pleura that causes pain. A lot of different causes: lung inflammation, pneumonia, tuberculosis. It can develop alongside with rheumatic diseases, chest trauma, cancer, asbestos, lots of different causes. And it's often called pleuritis or pleuritic chest pain. Influenza. Okay, so I'm going to get on my soapbox here for a minute. I try to limit these with you guys, but here we go. So first I will say, okay, who's most susceptible to severe complications? Older adults, those who live in close quarters, like dorms, and those with compromised immune systems, diabetes, or chronic heart, lung, or kidney disease. I cannot tell you how many times in my office somebody will come up and be like, I don't need to get my flu shot, or because I get it and I get the flu anyways. So it's important to distinct, like colloquially, people say the stomach flu. Stomach flu is completely different. True influenza doesn't have any GI symptoms. It's that, you know, fever, chills. I feel like I got run over by a truck. I have this awful cough. This quote unquote stomach flu is really gastroenteritis. That's the nausea, vomiting, diarrhea for 3 days, and I can't keep anything down. So it's important in our minds to separate that. And also, influenza is typically a much more severe illness than like just an upper respiratory infection. It hits you a lot harder, you feel a lot sicker, okay? So flu shots are our best way to help with this. But it's also important to know that, you know, every year a flu shot is a guess, okay? They're trying to predict which strains of influenza are going to be the most common, okay? And sometimes we get it absolutely wrong. But what we do know is that some of that protection lingers over multiple years. So because I work in healthcare, I work with immunocompromised patients all the time. I've been getting my flu shot for a long time. So say I've been getting it for 10 years and there's 4 strains in each flu shot. I potentially have some level of immunity to 40 different strains. So we need to think about flu shots over a lifetime and not just from year to year, okay? COVID has really shown us that viruses can wreak havoc on young, healthy people. And so can the flu. So just to a lesser extent. So it's important that we're doing everything we can to both protect ourselves and those around us. Okay, and soapbox. Okay, upper respiratory infections, it's kind of a garbage diagnosis. Saying, hey, I think you have a viral infection. It'll go away on its own. They are like highly transmissible through contact with infected respiratory droplets expelled by coughing or sneezing. And this is why if you looked at the data for winter 2020 heading into 21, like colds and flus were way down, way down, because people were masking, they were washing their hands, they were staying apart. And so these issues weren't as common because we were putting a stop into that transmission. Ideally, people would, wash their hands and such outside of, a global pandemic, but, I digress. Okay, and then this wasn't included in your book, but I felt like I needed to tell you because, your athletes will ask, you will struggle with it as well. So how do we treat a URI? Actually, zinc has been shown to decrease the length of time of colds. Okay. You can try Mucinex in water to thin the secretions. Important to note that Mucinex is only as good as how hydrated you are, because Mucinex works to thin those secretions out, and it needs more water in order to do that. You can add in a decongestant to help with all that sinus pressure. Other than that, rest and hydrate. And then this is a big question. When do I want to see you or them? After 7 to 10 days of continued symptoms. Pretty much all the time. If you come in on day 4 or 5 of your cold, I'll be like, well, it could still be a virus. Let's hang out for a few more days, try these things, and if you're still sick, call me. But another time that I would want you to come in to see me is what's called a double sickening. And what that means, this happens a lot with sinus infections. It means, okay, I've been sick for about 5-6 days. On day 7, I was feeling pretty good. I thought I was over this. I thought I was on the mend. But then day 8, I felt awful again. So that's called a double sickening. So oftentimes what that means is that like a bacteria or something has come on board on top of the virus. And so that's when you should come in, because most of the time an antibiotic is indicated at that time. Okay, tuberculosis. First, let's just talk about, who's at risk. People immigrating from countries with a high transmission rate, people living in prisons, the homeless, IV drug users, and HIV positive people. It's a highly contagious bacteria that typically infects the lungs but can spread to other organs. It's infectious by inhaling droplets. You develop these like granulomas in infected tissues. And it's also important to note latent TB. So if I was exposed to TB today, it is possible that I would go into active tuberculosis, which would give me the symptoms of, cough, fever, night sweats. But then it's also a possibility that I would go into latent TB. And what that means is that the TB is just kind of hanging out in my body. It's not doing anything. I don't have any symptoms, but it's there. Okay. And there can be a lot of different things that can make latent TB progress to active TB. Okay, so like steroid use, anything that kicks the immune system down at all. So steroid use, other infections. Unfortunately, if people need to be put on like, immunosuppressive therapies. So that's part of why we do so much TB testing, is to develop also those people that have that bacteria just hanging out ready to wreak havoc. Lung cancer is one of the most common types of cancer and leading cause of death from cancer. Mainly smokers, but not all of them are that. You do have an increased risk with secondhand smoke. Generally, unfortunately, it's a pretty poor prognosis as it's often not detected until later stages. There's a pretty specific guideline available about who should be screened based on their, pack year history and such. And any smoker over, I want to say 55, should have a CT scan every year to look for lung cancer. Okay, pneumothorax. This is a result of gas or air trapped into the chest wall between the parietal and visceral pleura, causing the lungs to collapse. Okay, a hemothorax, on the other hand, is as if it's blood pooling in that area instead of air, and that's mainly from trauma, but could also be from malignancies. It's considered a spontaneous pneumothorax if it occurs in the absence of traumatic injury to chest. In athletes, the most common cause is a rib fracture. Like I said, well, that sounds bad. How do I know what's going on? So if your patient or your athlete has a sudden onset of pleuritic chest pain and dyspnea, okay, say it's a football player who got hit and there's a chance he fractured something, I'd really be looking for this. There's also a shift, there can be a shift of the trachea away from the affected lung, because what's happening is that air is escaping and increasing the pressure within the lung, within the chest cavity, and is kind of pushing everything else and squishing everything else to the other side. Okay. An attention pneumothorax, where there's enough air escaping that it's pushing that trachea, can be deadly if it's allowed to progress, because it pushes there's so much increased pressure that it can actually cause the heart to stop. And so I wanted to highlight, some general principles in medicine. When you're evaluating a patient, first thing you need to think about deadly causes first. Okay, is this something that is acutely going to kill this person? Then you think of common causes, like what happens the most that could be explaining their symptoms. And then you look for your zebra, which is like the wild out there diagnosis. So this is just pictures demonstrating what I just talked about. So that collapsed lung, and then let me do this again. So, and then all of this air comes out here, and it's pushing everything that way. And then if it pushes too much, then the heart can stop beating. And then over here on the right, that hemothorax is from blood. And then this is an example of that tracheal shift and when you're getting into attention pneumothorax. Okay, so hot topic of the moment. So I felt, because, we're talking about respiratory illnesses, that I would be doing you a disservice if we didn't talk about COVID. And part of what I'm going to discuss is things for maybe you and those around you and your athletes as well. Okay. A few disclaimers to start with. Okay. There's very few things in our world that have been as politicized as COVID. Okay. Which is unfortunate, because the vaccine in general was, developed under a Republican administration. It's being administered largely by a Democratic administration. And it's hard, because no matter where you fall on that spectrum, both sides are telling you really different things. And we all have some level of science background, so we can try to piece together the information that we're given, but the majority of the population doesn't have that. Okay, so it leads to a lot of misinformation, a lot of misconcepts, and so it's our responsibility as as people in healthcare to help educate people. Okay, so almost 43 million cases have occurred just in the US. Okay, and then 686,000 deaths have happened in the US. And in order to dispel the how is the cause of death determined? Because one thing I hear a lot is, oh yeah, they say that it was from COVID, but was it really? And guys, in order to have this discussion with you today, I actually read like the coroner medical examiner like guidelines, which is this ridiculously long and boring document. So essentially, cause of death, and when I sign death certificates as well, I have to say what is the last thing that occurred to that patient that could be causing their demise. And then I also have to list, are there any underlying conditions that could have played a role in this death? Yes. The other day I signed a death certificate for like a 99-year-old lady. And so I'm like, do I know exactly why she died? Nope. But you know, these are all the different things that, because she just died at home, kind of in her sleep. But these are all the different things that were going on. So with that information, we know that COVID-19 can cause blood clots. It can cause respiratory failure. And if that is the thing that kills them, it doesn't matter. It is listed, and maybe their symptoms were worse because, you know, they had diabetes or lung disease or kidney disease or whatever. But that last final thing is what's listed first on their death certificate. So let's just, because we're doing this, let's just define COVID. It's a virus caused by SARS-CoV-2. Most people with COVID-19 have pretty mild symptoms, but some can become really ill. And although most people with COVID-19 get better within weeks of illness, some people experience post-COVID conditions, which we'll go through as well in a little bit. Okay. Okay, so there's a lot of press about variants right now. Variants are expected. Viruses mutate. That happens all the time. And the best way to slow the emergence of new variants is to reduce the spread of infection by taking measures to protect yourself, including getting a vaccine. I'm going to talk about the vaccines more in a little bit, but vaccines can help keep you from getting sick, being hospitalized, or dying from COVID, but it also stops you from allowing the virus to mutate if the majority of the population is vaccinated. All COVID-19 tests can detect all variants, but they won't tell you which variant you have. I don't know the exact number, but say every 10th or 100th test or whatever is sent off to a specific lab in order to determine which variant it is. And that's how they're able to say what variant is most prevalent in wherever. Important to think about Delta, which is what we're dealing with the most right now, spreads faster and is more likely to cause more severe illness. And then unfortunately, certain treatments are less effective against Delta. And so the concern is that if Delta is already worse than like Alpha was, and Alpha killed that many people, what comes after Delta? Okay, is it going to be even worse? If we don't get this under control, what are the other variants going to be? And you have to think about it like antibiotic resistance, okay? Or like people who don't finish their course of antibiotics. So if I'm prescribed 7-day course of antibiotics for a UTI and I only take 4 days of it, really what happened is I killed off the weak bacteria and left the strong ones, okay? And so then, because I didn't saturate the tissue enough, and so then what bacteria is left is stronger than what was there before. So when that replicates, it's easier for it to pass along, the better DNA to cause worse and worse infections and to be resistant to my antibiotics. Okay, symptoms of COVID, we've all heard this like a million times: fever, cough, chills, shortness of breath, fatigue, muscle, body aches, diarrhea. It really just goes on and on and on. Headaches, new loss of taste of taste or smell, sore throat, congestion or runny nose, nausea, vomiting. But here's the struggle, guys. The symptoms of those are the symptoms of, any number of respiratory viruses. So it's really hard to know what is what, and that's been a big struggle in healthcare recently. Symptoms can occur anytime between 2 to 14 days from exposure. When do you need to seek advanced medical care? If you have trouble breathing, persistent pain or pressure in the chest, new confusion, inability to wake or stay awake, pale gray or blue colored skin, lips or nail beds, once again depending on skin tones. Okay, long haulers, COVID symptoms. This is called a lot of different things, but long haulers makes the most sense to me. Important to realize that there's no more virus in the body. That's not what's causing their symptoms. Risk factors for developing long hauler COVID is high blood pressure, smoking, diabetes, obesity, and this is something that we're learning more about like every day. The most common lasting symptoms are fatigue, shortness of breath, cough, joint pain, and chest pain. And people also say they get a lot of like cognitive problems, such as like difficulty concentrating, depression, muscle pain, headache, rapid heartbeat, and intermittent fever. Okay, so let's take a break and say, okay, why do I care so much, right? Like, what difference does it make? We've already talked about, how many people have actually died of COVID, but let's talk about, but for the rest of us, like, honestly, who really cares if, I have a stuffy nose and a headache or whatever for a couple weeks? Why does that matter? So this is why it matters. Even in people who have mild cases can develop long-term effects. There can be lung scarring that can take months for a person's lung function to return to pre-COVID levels. And sometimes people even have persistent shortness of breath even after just light exertion. And we see this not just in, old, unhealthy people. Like we see this in young athletes and in triathlon runners. People can have heart problems. One study showed that people up to 60% of people who had recovered from COVID had signs of ongoing heart inflammation with symptoms such as dyspnea, palpitations, and a rapid heartbeat. You can get pretty severe kidney damage. I had a patient come in recently who was so upset because she lost her sense of smell. And she's like, it's pumpkin spice season and I can't smell anything. And I'm like, sorry, I can't do anything about it. Luckily, most people develop or get their sense of smell and taste back within a year. But if you think about it, that's a pretty long time. That's a long adverse event after an infection. You can also have that brain fog, fatigue, headache, and dizziness last for a long, long time too. So what treatments do we have? What we start with for mild cases is similar to that URI, rest and hydration. And then, we try to support people's oxygenation, even if that's just, a nasal cannula, all the way up to ventilators. And it's a scary place when somebody gets put on a ventilator with COVID because their chances of actually coming off of it, unfortunately, are not good. We can also use corticosteroids to help a little bit. Monoclonal antibodies is a relatively new treatment. It's also considered experimental, and it's also under an emergency use authorization by the FDA. but that tends to not, people aren't as, on board with that at that point in time. So let's talk ivermectin. People swear by it, and the FDA has actually specifically come out and said do not use ivermectin for COVID. It's technically an antiparasitic drug that, I don't really ever prescribe. I can use it for scabies, but I mean, there's not a lot of indications for it. And please do not go out, and it's used more often in animals to get rid of their parasites. Oh, and one more note about the monoclonal antibodies. Different areas are able to prescribe it. I am now able to, but there's a very specific timeline from when I can give it to people. So the earlier people get tested with their symptoms and the earlier they present to me, the better chance I have of actually being able to give them this treatment. So this is a graphic about how mRNA vaccines work. I'm not going to go into it in detail. Essentially, they teach our cells how to make a protein or even just a piece of a protein that then triggers that immune response. They've been working on mRNA vaccines for multiple decades. Even they'd been working on an mRNA vaccine for coronavirus. They just then made it one for this specific virus. And the stuff that we inject really lasts in the body only a couple of days. The spike proteins that it's making your body create last a couple of weeks. It does not enter your nucleus. There is no way for it to change your DNA. Side effects of vaccination. This is, purposefully dramatic, but longevity. You're a lot likely to live longer. But, myocarditis and pericarditis have been an issue. It's very, very rare, but it occurs more often in, young males after the second dose of vaccine and within several days after vaccination. So if it's been multiple weeks, it's likely not from the vaccine. The symptoms of this would be chest pain, dyspnea, palpitations. But even the people that do develop myocarditis or pericarditis, it's typically really mild, self-limiting, responds well with rest, and a lot of times they don't even need medication. But because of the severity of it itself and the potential risks, these patients should consult with cardiology prior to resuming their activities.